Good morning, everybody. We'll get started here in just a moment as everybody gets joined in. All right, I'm seeing our numbers continue to go up, so I'm going to give it just another minute, make sure everybody gets logged in, and then we'll get started. All right, good morning, everyone. Welcome to the Mid-Atlantic and Northeast Regional Community of Practice Professional Training event. We're going to be focusing on improving access to behavioral health services for active military and veterans. This training is presented by Serving Together, a program of EveryMind, as part of the Regional Community of Practice efforts for the AmericaServes Mid-Atlantic and Northeast regions. This project was supported under a grant awarded by the Walmart Foundation to Syracuse University. This event will be recorded and shared via YouTube video link and be shared out via email to you after the event has ended. We will also be sharing the slides. We sent them to you before the event. However, our keynote presentation by Terri Tanielian slides will not be shared. We will be sharing additional information about resources that are available that she references during her presentation. You can utilize the chat to communicate with participants and panelists. If you have any questions, please use the Q&A feature. These questions will be either addressed during the Q&A session or toward the end of the event or privately. As many of you are familiar, EveryMind is a nonprofit organization out of Montgomery County, Maryland, whose mission is to strengthen communities and empower individuals to reach optimal mental wellness. We provide a variety of direct services for the entire lifespan, including a 24/7 hotline, homeless outreach, school-based mental health services, and much more. We also strive to reduce the stigma surrounding mental illness and increase the importance of mental wellness for everyone. For more information, please visit our website at every-mind.org. One of our programs is Serving Together, and it's focused on providing resources and assistance for military, veterans, and their families in the National Capital Region. Among our objectives, we strive to provide education to the community to help better support service members, veterans, and their families and caregivers. Serving Together in EveryMind, we're selected to serve as the Regional Community of Practice Champion to support the work in the Mid-Atlantic and Northeast regions, with the goal to provide educational training opportunities to our network users, from Serving Together in the National Capital Region to Mission United in Southampton Roads, to PA Serves in Greater Pittsburgh, to now Rhode Island Serves and RI Serves in Rhode Island, and New York City's Vet Connect NYC in New York City. We conduct these trainings based on feedback we have received from you, and we have more events lined up, but it's crucial we receive your feedback to provide the most requested topics you need. We will also have a link provided at the end of this webinar requesting your feedback. We encourage you to provide feedback so we know how the event went today, but also what future information you would like to receive. With that, I want to introduce our keynote presenter today. Terri Tanielian is a senior behavioral scientist at the RAND Corporation. Tanielian is a nationally recognized expert in military and veteran health policy. Her research interests include access to and quality care for service-connected health problems, particularly mental health problems, military and veteran suicide, military sexual assault, military families, veteran caregivers, and psychological and behavioral effects of combat, terrorism, and disasters. She employs both quantitative and qualitative research methods and analysis in her work, including surveys, interviews, focus groups, and analysis of administrative data, as well as environmental scans of existing policies, programs, and services. Tanielian served as the inaugural RAND Congressional Fellow with the House Veterans Affairs Committee, where she focused on informing legislative opportunities designed to support comprehensive suicide prevention strategy. She also served RAND liaison to the Department of Veteran Affairs and as a senior fellow in the Military Service Initiative for the George W. Bush Institute. She formerly directed RAND's Center for Military Health Policy Research, overseeing RAND's diverse military health and research portfolio. And in this role, she was interacted regularly with senior military health officials to identify and develop policy relevant studies and advise on the use of finding to improve decision-making. She was the co-study director for RAND's seminal study, Invisible Wounds of War, Psychological and Cognitive Injuries, Their Consequences and Services to Assist Recovery, the first non-governmental assessment of the psychological, emotional, and cognitive consequences of deployment to Iraq and Afghanistan. She won the Academy Health Impact Award for this work in 2011. She also has the principal investigator for RAND's comprehensive study of military and veteran caregivers titled Hidden Heroes, America's Military Caregivers. She's led the first prospective longitudinal study of military families across the deployment cycle and the deployment life study. She's conducted several assessments examining the challenges and issues facing veterans living in Detroit metropolitan area, Massachusetts, and in New York State. Her studies have also examined the readiness of private sector health providers to deliver high quality care to veterans. She's led a study examining community-based models for expanding mental health care and returning veterans and their families under the Welcome Back Veterans Initiative, as well as consensus building effort to design a blueprint for future research on veteran caregiving. She's published over more than 100 peer-reviewed articles and books and chapters, and she has served on many advisory committees, expert panels related to military mental health policy, public health preparedness, and Homeland Security. She has an MA in psychology from American University. And so with that, I would like to turn it over to Terri to kick us off this morning.
Well, good morning, and thank you, Christy, for the introduction, and I'm really pleased to be here. And while we can't gather in person, I do hope that we find you all safe and keeping healthy. As Christy mentioned, I have been working on this topic for nearly 20 years at my time at the RAND Corporation, and it's one that is really near and dear to my heart, and I'm very passionate. So I'm going to go ahead and share my screen so I can kick off our presentation today. And in our time together, I am going to be covering quite a bit of material. So I ask for your patience as I talk a little fast, and I look forward to your questions when we get to the Q&A portion. But today I'm really going to cover some of the big topics around the prevalence of the behavioral health issues that face our military veterans here in the United States. I'm also going to talk about some of the barriers to care seeking that we know that create obstacles for them getting the help that they need. I'm going to then give an overview of the systems of care and talk a little bit about how challenging it can be to navigate those systems of care. And then finally, I'm going to talk about some evolutions and innovations on the horizon and that are occurring now in serving this population, and then wrap up with some conclusions. All of the work that I am going to share with you today is available through published reports on the RAND website or on other sources that I'll point out as we go along. So let's go ahead and get started. To put things in context, I think it's important to recognize, the veterans in the United States represent about 7% of the adult population. We know that they span multiple eras of service. The Vietnam era veterans represent the largest cohort of a single service era, although we see that Gulf War and post 9/11 veterans are about 7.6 million individuals, and those represent the veterans that have served in the all-volunteer force. And now, veterans as a population are different than non-veterans in some important ways, and it's critical to understand those distinctions and differences if we're really going to be able to meet their needs. Veterans are older on average. They are 65 years old, and they are more likely to be male. While the percentage of female veterans is increasing, at present it's only about 9% of the total veteran population. We also know that veterans as a group tend to be sicker and have more chronic health conditions and greater healthcare utilization. We know that this population is also changing over time. And over time, we expect as our older era veterans diminish in size, we will see that our post 9/11 veterans become an increasing proportion of the population. Our post 9/11 veterans are a population that has also received a lot of attention in recent years due to the conflicts in Iraq and Afghanistan and the impacts of serving in those wars. So I'm going to talk a little bit about that population and what we've observed in terms of their behavioral health challenges. So who are these post 9/11 veterans? Again, they are different. They look characteristically very different than their older service counterparts. On average, they are 36 years old. We see that they're 17% female. They're increasingly diverse, more diverse than, again, older era veterans. But they're also most likely to be employed and have attended college. We also know that families are a critical component for attending to the needs of this particular population. Over half are married and nearly half have children living in the household. And so while I'm going to talk today specifically about the needs of veterans, I hope a future topic will be looking at the needs of their family members as well, because it will be critically important to understand how those are unique from the civilian population as well. We know that post 9/11 veterans are at high risk for experiencing behavioral health problems. There have been now a decade or more of research documenting the prevalence and challenges that this cohort of veteran faces. It's important to reflect that as we call these invisible wounds of war, PTSD, depression, these invisible wounds are not necessarily new. In fact, these types of consequences are as old as warfare itself. So whether or not we've called it shell shock, battle fatigue, soldier's heart, what we now understand to be post-traumatic stress disorder, even combat-related depression, as well as traumatic brain injury, we can see evidence of these types of consequences as far back as we've been documenting war-related experiences. And so while these concepts and consequences are not new, we do need to pay a lot of attention to them because they can be quite severe and have important impacts on our society. And one area in which we're very concerned is the impact that military life may have on suicide risk. We know that veteran suicide is a national public health concern and a national security challenge. We have seen about 6,000 veterans die by suicide each year over the past several years. And we see that the largest number of deaths occur between those veterans aged 55 to 74. And while the total number of deaths has remained somewhat stable, of concern is that we're seeing a rise in the suicide rate among our youngest veterans in the age group between 18 to 34. So as this rate of suicide has been increasing, it's really imperative that we continue to understand some of the risk factors associated with veteran suicide. And one of those risk factors is understanding and addressing the behavioral health challenges that they face. So for the next several slides, we're going to talk a little bit about what these behavioral health challenges are. And as I said, now we've seen hundreds of studies that have been conducted trying to document the size, scale, and scope of these behavioral health issues as they affect the post 9/11 population. We've seen that the rates of post-traumatic stress disorder range between 11 to 20%. The rate of depression, a major depressive disorder, range around 13 to 15%. And I highlight here also the range around experiencing a substance use disorder, which hovers between 11 to 24%. These ranges are driven in large part by the population that has been studied, as well as the screening tools that have been used. But one of the things I really want to highlight is the amount of co-occurrence that can occur among these disorders. We, in a recent study that was released earlier this year, did review this literature and found that between a third and almost to 90% of the veterans who have been diagnosed with PTSD also have a substance use disorder. And among the veterans that have a co-occurring behavioral health problem, alcohol use disorder is the most common of those. Why is this an issue that we need to pay attention to? Well, we know that using substances and having a mental health problem can create a vicious cycle, particularly for veterans. Veterans may use the substances to cope with PTSD or depression, perhaps to self-medicate, to bring some numbing to help them sleep. But we also know that it can be a challenge to their treatment engagement, particularly if treatment programs require abstinence or not using any of these substances. We know that untreated depression and PTSD could exacerbate substance use and so increase the desire for someone to be relying upon these medications. And they can, in fact, exacerbate some of the symptoms that veterans will experience with PTSD and depression. So we really need to focus on addressing substance use disorders as well as the mental health problems that have been talked about so much in this population if we are to break this vicious cycle. In these next couple of slides, I'm actually going to share some data that is from the Substance Abuse Mental Health Services Administration's National Survey on Drug Use and Health. And these data are publicly available. You can download these exact same slides from the SAMHSA website. But I think it's important to kind of put the challenge that our veterans face in this area in context. And so in these large circles, you see the percentage or the number of people in the United States who are experiencing these problems. And in the call out boxes, you see that veterans are more likely to experience some of these challenges than non-veterans, with 1 in 4 veterans experiencing a mental illness. And we see 4 in 5 veterans struggling with alcohol use problems. So I'd like to unpack these findings a little bit. We see that alcohol use disorders, as I mentioned in the previous slides, does affect 1 in 4 veterans, but the experience with alcohol use disorders does vary by age, and we see that is more common in those age 18 to 25. Again, I'm going to reflect that this is part of the group that we're also seeing the increasing suicide rate among. We know that illicit drug use among veterans, while it is less prevalent than it is in the non-veteran population, we still see that marijuana is the most used drug among veterans. We see again here a similar pattern that use of marijuana is more common among those 18 to 25. And we also know that the use of opioids and opioid addictions in particular have been increasing in our overall population, but we're seeing a similar pattern among our younger veterans as well. And so it is really of concern to see some of these increases, and we need to kind of paying attention to some of these behavioral health co-occurring problems as well. This slide, I think, really kind of drives home the point about the relationship between having a substance use disorder as well as thoughts of suicide. And so you can see in these graphs that those veterans who experience a substance use disorder are much more likely to have reported having serious thoughts of suicide, making a plan, or having attempted suicide. So again, if we're going to be talking about reducing risk and preventing suicide, we need to be talking about addressing the substance use problems that our veteran population faces. But the challenge becomes that of those veterans who are experiencing substance use problems, we know that nearly 90% are not receiving any treatment. We see also a major gap in untreated mental health problems among veterans as well, where 53% are not in any care for their mental health problems. And so these gaps are really quite concerning. We know, and some studies that we have done over the past 12 years have demonstrated the consequences associated with untreated post-traumatic stress disorder, depression, and traumatic brain injury. And we actually know that these can contribute to large costs to society. We've relied upon this model that has demonstrated that experiencing one of these conditions can lead to other types of consequences. I've already talked about the co-occurrence of these conditions with substance use disorders, but we also know experiencing PTSD, depression, or traumatic brain injury can also lead to other poor health outcomes. It can contribute to relationship challenges. It can lead to problems in the workplace and with employment. And we also know that it can impact retention in the military. Over time, we see that these can also cascade into other impacts within the family, on the child, decrements in wealth achievement for individuals who struggle with these types of conditions. And we also know that it may contribute to homelessness, as well as premature mortality. And so really understanding this model kind of underscores the importance of trying to intervene early and to kind of break these relationships so that we can offer hope for veterans that they will not experience some of these later and downstream consequences. However, as I mentioned, too few veterans with these problems are actually seeking out treatment. And so understanding the barriers that this population faces is really important if we're going to design policies that will help us overcome and promote help seeking. Many veterans report barriers to care that are similar to non-veterans, such as concerns around eligibility and having provider availability and being able to get an appointment in a timely way. But veterans report barriers that are also unique. One of them is the concern that getting help might have a negative repercussion on their career. For example, the fear of losing a security clearance is often the most common reported barrier for veterans about seeking care. We also know that veterans have particular preferences about the types of treatment and the provider's cultural competency. They want to know that the provider that they see understands what it is like to be in the military and to perhaps walk in their boots. And so these barriers, again, are critical to understand how we can introduce both programs as well as policies to overcome them. And I'm going to highlight some of the interesting findings that we've had about the attitudes that veterans have about behavioral health care, because these really need to be targeted with better education. And hopefully some of you all who are providing some of these services can help educate and inform veterans about the effectiveness of mental health care. We know that many veterans are concerned about the side effects of medications, but they also are concerned that mental health care may not be very effective. And certainly if we look at the status quo in the United States, we know that not all providers are delivering high quality evidence-based care. So in fact, on average, care may not be very effective in regular settings, but we know that it can be if the right therapies and treatments are provided. And so it really is ensuring, that we can provide access to these appropriate treatments if we're going to ensure that we can promote recovery and better well-being for veterans that experience these behavioral health problems. And so over the course of several studies, my colleagues and I have reviewed the literature to look at what the science says about various different techniques. And there are many, many research-backed or evidence-based approaches that are very effective in treating post-traumatic stress disorder, depression, and substance use disorders. And while the strength of the evidence underlying some of these approaches may vary, the research is clear that if these types of interventions are provided with fidelity, that means that the provider is actually implementing it to the full intention and kind of in compliance with the protocols that have been outlined. We do have hope and can offer recovery for symptom reduction, as well as resolution for veterans and a reduction in suicide risk. As I highlighted, an area of concern, however, may be when veterans experience co-occurring behavioral health problems, and the concern that many treatment programs kind of treat these conditions independently or separately. And so in a recent study that we just released, we looked at the evidence base for offering concurrent treatment or integrated approaches. And so on the left side of the screen, you see some of those techniques and approaches that we found had evidence of efficacy that support their use and integrated approaches so that you're treating the substance use disorder as well as the mental health problem simultaneously in the same setting with the same therapeutic approach. And then on the right-hand side, we see some that also are offering some promise, but that need further study. And so we know that these treatments are out there, but how do we know that they're being delivered? And so I want to talk a little bit about the systems of care that serve our veterans, and then outline kind of whether or not these systems are able to provide these types of interventions. So I'm going to talk about three main systems of care. I'm going to start with the military health system, and then I'm going to turn to the VA healthcare system and also talk about the private sector. We know that these populations served by the military health system, as well as the Department of, which is operated by the Department of Defense, as well as the VA healthcare system, overlap. And so this slide just really demonstrates where they overlap. And so we can see that some of those older veterans, particularly over the age of 65, may be served by both the DoD healthcare system as well as the VA healthcare system, but they're also covered by Medicare. And so they have multiple options for receiving services. The military health system is primarily designed to provide services to support the active component military personnel. In the 1960s, it was really expanded to also cover family members as well as some military retirees. And that population has grown. At present, there are 9.6 million eligible beneficiaries. It offers services through what's known as the TRICARE plan, and that can be through direct care system, which is care provided in military owned and operated treatment facilities that are distributed largely around installations, as well as through the purchase care sector, where they rely upon a network of providers that have been compiled through a third-party administrator. And at present, there are about 550,000 purchase care providers within TRICARE. Within the VA, we know that the VA actually operates the largest integrated healthcare system in the United States, actually the second largest integrated healthcare system in the world, second only to the National Health Service in the United Kingdom. This system has evolved and is designed specifically to address the unique needs that face the veteran population. It offers a very large footprint, and similar to the military health system, it has always historically relied upon both care provided within the VA healthcare system through, again, government-owned and operated hospitals and outpatient clinics, as well as care that it has purchased from the community as needed, and that has evolved over time. It is important to kind of understand that not all veterans in the United States are eligible for care through the VA healthcare system. And so we know that, as I mentioned up front, there are about 18 million veterans residing in the United States today. Only about half of them, or 9.2, are enrolled in the VA healthcare system. And in last year that the data are available, we saw that only about 6.4 million of that 9.2 used care or were unique users in the VA healthcare system last calendar year. On this slide, I describe a little bit about the eligibility criteria for who can enroll in the VA healthcare system. And for anybody who has tried to read the code that outlines these eligibility, I know it can be somewhat confusing, but the way in which that the VA has organized its priority groups is intended to try to give precedence and priority to those veterans who have service-connected disabilities, but also may have less access to healthcare outside. Even of those veterans that use the VA, it's important to recognize that they also have access to other forms. Many of them have access to other forms of health insurance and may rely only on the VA for a portion of their care. So as I mentioned, the VA and the DoD rely upon the private civilian healthcare system through which they purchase services for their enrollees or beneficiaries as well. Over time, we've seen a shift in the landscape for veterans care in particular. We know that more veterans seek care outside the VA, either because they have employer-sponsored health insurance or through preference not to rely upon the VA. In some early work that we did with post 9/11 veterans, we heard from them that they would wanted to preserve the VA healthcare services for veterans that they felt needed it more, particularly referring to the Vietnam era veterans. And so we know that more veterans may seek care outside the VA. We also know that efforts to accelerate the use of community care by the VA have been enacted by Congress, both in 2014 and more recently in 2016. So while the reliance and use of purchase care or community care in the VA has been increasing over the past decade, recent efforts have served to only accelerate this trend. We've also seen a number of initiatives in the private sector, largely in the nonprofit arena, that have attempted to fill the gaps that may exist in the care systems, and particularly have designed programs that would help some veterans overcome those obstacles and those barriers to care that I mentioned a few slides ago. And so, as Christy mentioned, I had the opportunity to do some work with the Welcome Back Veterans Initiative, and through that was really a great opportunity to understand the evolution of some new innovative approaches in the private sector and the nonprofit arena in particular to address the behavioral health needs of veterans. And so these are just a few illustrative examples. I think we're going to hear more about the Cohen Veterans Network during our panel conversation, but just to highlight a few others, the Warrior Care Network consists of 4 academic medical centers that work collaboratively to offer both regular outpatient care as well as intensive outpatient care. These are located at Massachusetts General Hospital Home Base Program in Boston. We have the Road Home Program at Rush University, Operation Mend, which is out at UCLA, and then we have the Emory Veterans Healthcare Program down in Atlanta. We also have seen some other innovations and approaches. There is the Headstrong Project, which now exists as a network of providers who provide EMDR in partnership with Weill Cornell, and they are now located in 13 different locations across the country. STAR Behavioral Health Providers is a registry of sorts that has trained providers through a series of tiers and exists now in 9 states and largely serves as a referral network for members of the National Guard and Reserve. We also have seen some innovative partnerships with the Department of Veterans Affairs. The Unified Behavioral Health Center for Military Veterans and their families at Northwell Health is a clinic that serves military families and veterans families that is co-located with the VA CBOC out on Long Island. And then many of you have probably heard of the organization called Give an Hour, which is a volunteer-based organization with providers all over the country. One of the newer approaches that is really quite exciting is the Marcus Institute for Brain Health, which is now based at the University of Colorado. This is based upon the NICO model, the National Intrepid Center of Excellence that focuses on traumatic brain injury and co-occurring psychological health challenges. And so with the Marcus Institute of Brain Health, they are actually working to grow their network as well and expect to expand to 10 sites over the next 3 to 4 years. And so as this growing array of opportunities has expanded and come onto the scene, it raises a number of questions as well as the growing reliance upon purchase care in the private sector of what really is the readiness and the preparedness of private sector providers to be able to address the needs of veterans with behavioral health problems. So my colleagues and I have now done a few studies on this topic, and we've been primarily focused on trying to understand how well private sector providers are prepared to deliver timely access to care for veterans, whether that care is culturally competent, that is, do the providers understand the issues that the military veteran population faces, and whether or not they're delivering care that would be considered to be high quality. And so we've looked at the providers both in mental health as well as across some other specialties and found some concerns and gaps in the preparedness and readiness of private sector providers. And so this slide just gives you the top level findings from one of these studies where we looked at an increasing kind of filter of this preparedness. And while we found that 92% of community-based providers were accepting new patients, so veterans could schedule appointments, as we layered on additional criteria or expectations, and expectations, by the way, that are expected of providers within the Department of Veterans Affairs, we found that 92% went down to 2%, calling into question really the preparedness and readiness of this purchase care system that the VA now is really increasing its reliance upon. And so there have been a number of studies, including ours, that have called for significant efforts to improve or increase the readiness of providers in the community sector. This includes not only providing trainings around military culture, but also information about how to treat service-connected health problems. We called for specific approaches that would increase and improve screening and use of evidence-based approaches. One of the areas of concern is, are community-based providers screening for suicide risk in a well kind of constructed way, and that offers appropriate follow-up. We also made recommendations about how to improve engagement with VA and available resources that serve veterans in their communities, so that integrated and coordinated services could be offered so that additional needs that veterans may have can be addressed, and then also the need for quality monitoring. And so with these recommendations and this effort to kind of ensure that the private sector is prepared to serve veterans with behavioral health problems, we've actually seen a cottage industry of training programs be created. And so a couple years ago, with funding from the McCormick Foundation, the Bob Woodruff Foundation, and the Cohen Veterans Network, Rand took a look at what does the science say about training in these different types of approaches, because not all trainings perhaps produce the same results with respect to teaching cultural competence or achieving competence in the delivery of specific interventions. And so I referenced this tip, this RAND tip tool, which again, you can find on our website. It provides a really interactive way for you to evaluate the attributes of different types of training programs, so that if you're considering whether it's a free web-based resource and a download that you can watch at your leisure, or if it's a multi-day training program that involves pretty intensive interaction and role modeling with some supervision requirements, you can see how kind of it rates on this spectrum from raising awareness to actually producing competency. And so this is really hopefully a good tool for providers and organizations who are looking at choosing between different types of training to increase their competency in addressing veteran behavioral health problems. And so while there have been a number of efforts designed to increase cultural competence as well as the use of evidence-based approaches, there are a number of other kind of innovative things that have been on the horizon. We know that the Department of Veterans Affairs has actually been a leader in the development and deployment of kind of digital health tools and apps that are on phones that can be used in conjunction or independent of psychotherapy. And so whether it's PTSD Coach or Breathe to Relax, we've seen the influx of mobile applications. We've also seen increasing use, particularly in the era of this pandemic, and the reliance upon telehealth and virtual health opportunities. We do know that there have been several studies documenting that the telehealth for particular types of therapies can be just as effective as in person. And so while we've seen an increased reliance upon telehealth, we still need to consider kind of the preference and the safety right now in this era of the balance between telehealth and in-person care. We've also seen an increased interest as well as an increased use of non-traditional or complementary and alternative approaches. There's a growing literature base to look at the role of acupuncture, for example, in treating post-traumatic stress disorder, and other efforts to try to study and understand the potential effectiveness of interventions like Tai Chi, yoga, etc. We've also seen a number of other non-traditional, non-medical models and methods that have come onto the market. And just as we've invested in our traditional clinical models to understand the efficacy or the effectiveness of those interventions, we need to give the same investment to these other models and methods as well, to ensure that we are first doing no harm, but that we are gathering information and evidence that they can promote symptom reduction. I think one of the key takeaways in understanding the science and the research underpinning how we address behavioral health problems in veterans is to recognize that there's no one-size-fits-all approach. Just like there's no one-size-fits-all approach to treating cancer, we need to recognize that there will be heterogeneity in response to different types of interventions. We know that veterans will have different types of preferences and those need to be considered and taken into consideration. However, we do also need to ensure that we offer the very best tools in the toolbox. We want to ensure that we are offering what we know works, and then working with veterans to get feedback and to monitor their progress and their outcomes, and to make appropriate modifications and tweaks over time as necessary, but also add additional elements if it's warranted. And, you know, commitment to being outcomes driven and outcomes focused is going to be really critical if we're going to be able to address the needs of the veteran population with behavioral health. And so I'd just like to wrap up by kind of really reflecting on, you know, that we know that behavioral health problems are common in the veteran population, but it's important that we recognize that the population is very diverse, and their needs and preferences for care are also going to be diverse. And while there's been a lot of attention on whether or not the VA is providing access to timely, high quality care, and private sector resources may help fill this need, we know very little about how well they're providing timely access. In fact, today, I think there's a hearing on Capitol Hill that is looking at the issue of wait times in the community for veterans. And so we really need to kind of commit to understanding how well we're able to address these, but ultimately working together in collaborative and integrative models and approaches so that we can ensure that we're meeting the needs of veterans in a more holistic and comprehensive way. So with that, I'm going to wrap up and stop sharing my screen and potentially take some questions if you all have some.
All right, Terri, we do have lots of great questions. So I'll start with the first one that I have at the top from Linda. She says, Terri, do you have any experience working with the Medical Expenditure Panel Survey? It would be great if RAND would push VA and AHRQ to pay for an oversampling of veterans so we could understand the financial impact of behavioral health issues.
That is a great question. And in fact, we have, and we do use the Medical Expenditure Panel Survey, as well as the National Health Interview Survey, the National Child Health Survey we just used to look at some TRICARE beneficiaries. And so there are a number of national health surveys or medical surveys that are conducted in the US population where there is a sample of veterans. And so you can make some comparisons. The challenge is that the numbers are typically small, and so you have to condense over years, and you may not be able to have as sensitive, your analyses may not be as sensitive to changes year to year. So that's a great point. And I and others, my other colleagues have been making several recommendations over the past couple of years about increased investments in data collection efforts for our veterans and our post 9/11 veterans in particular.
Awesome, thank you, Terri. Robin asks, is alcohol or substance use disorder an attempt to self-treat more severe mental illness, or is it a causative factor?
That's a good question. And I know that as I kind of reflected in that cycle slide, that we see that many may use substances as a means of self-medicating. And it can contribute to the exacerbation of symptoms for individuals, particularly as they're struggling with some of the post-traumatic stress disorder symptoms. And so I don't know that substance use disorder and use of substances is a risk factor for developing PTSD, but it is a risk factor for exacerbating the symptoms associated with PTSD. And so really trying to break that cycle is going to be critical. And as I mentioned, and as we see in the data, alcohol use disorder is the most common substance use disorder among the veteran population.
Awesome, thank you, Terri. Jessica asks, how can we better support veterans and their families so that the divorce rate declines? It is widely known that children perform better in life when they grow up with both parents in the home. So what do we do to keep the family intact?
So I didn't present the data today, but the study that Christy mentioned, the Deployment Life study, we did follow a cohort of military families across the deployment cycle to really try to understand the impact that deployment and some military life experiences, particularly like PCSing, the frequent moves that military families face, and try to understand the impact that it has. We also know that experiencing a behavioral health problem can have an impact on the family. And so intervening to address the behavioral health problems can also help preserve family. I think it's, there's always going to be some interesting and unique circumstances. I am not a marital and family therapist. I'm not a clinical psychologist. So I would count on the panelists that are going to follow me to maybe address some of these issues. However, I've often kind of had to think about, is divorce always a negative outcome? And certainly, we have seen the data that family dissolution can have a negative impact on child outcomes. But if there are other issues that are happening within the household, perhaps pathways to more healthier lives are found through family dissolution as well. So again, I think it's going to vary by the individual circumstances, but interventions designed to address the behavioral health issues of any individual in a family, as well as those focused on, improving family communications and family relationships may help. But I would defer to some of the clinicians on the next panel as well.
Thank you, Terri. I'll definitely save that one as well to readdress during our panel discussion. Stan Seidel asks, and this may be a question that also can be addressed a little bit more with the panel as well, but according to data received from the VA, only 50% use the VA, and with COVID, the percentage now is lower. The problem is marketing to veterans and their families about treatment. So what is being done? Have you seen any updates on how they're increasing the marketing to veterans and what could be improved from your perspective?
Sure. Well, over the past 15 years, really, there have been multiple efforts designed to kind of promote education and public awareness of the psychological and behavioral health issues that face this population, but also to try to encourage treatment seeking. And so there are a number of campaigns that have been implemented within the Department of Defense, like the Real Warriors campaign, which offers a suite of resources, but also has a number of educational outreach activities. Similarly, there have been those led by the Department of Veterans Affairs. Make the Connection is actually a really good campaign. They've had some others around suicide prevention and Be There. And so while I didn't talk about it, I can direct you to some work that we've done evaluating DOD's, VA's, as well as HHS's kind of public education campaigns on promoting mental health treatment. But recently, the VA has actually started the Solid Start program, where they are reaching out to transitioning service members to find out how they're doing and to make contact. And so that outreach is one mechanism. While it's not advertising, it's a personal touch and a personal phone call to try to check in and see how the veteran is doing. And again, educate them and make them aware of the potential services that they may be eligible for, and offer them referrals and sources of support. There have been a number of efforts by private entities as well. There are a number of nonprofits that have also launched kind of these public awareness campaigns to try to reach out and engage the veteran population and community.
Awesome, thank you, Terri. Jamal asks, how can life coaches be of assistance with the veteran's needs and helping with setting up goals, motivation, and staying positive? Do you have any, thoughts on life coaches?
I don't, but it is, I think interesting. I think, goal setting, kind of problem solving, can kind of help many of us in many respects. So I've not studied, the specific interventions or the impact that they have. So I really can't comment. But, to the extent that we are trying to offer holistic and comprehensive approaches to support veterans, that may be challenged and struggling with behavioral health problems, we know that there's again not just one potential thing that can help.
Awesome, thank you, Terri. In terms of training providers, Linda asks, the VA already brings social work and medical school students to the VA medical centers and the community-based outpatient clinics. However, schools of clinical psychology, family therapy, pharmacy, nursing, etc., could do more to increase exposure of students to veterans and their families. And it's not quite a question, but I wanted to know if you had any thoughts on that statement.
Yeah, so there had been some focused energy and effort about a decade ago to really work with schools, professional schools, to develop curricula and to bring some of that training and curricula right into graduate training. And various, I think, universities as well as different professional associations have responded differently. Like the American Nurses Association, for example, has a whole campaign around Ask the Question. And others, have implemented curricula. I know, even schools of social work have created, certificate programs on military social work, for example. And so I think the response has been varied over time. And that, like I said, there's been a private cottage industry created. So you can go online and you can find kind of free trainings, but you can also register for courses, some, that are lower cost and some that are higher cost. And so it really is kind of a wide array of programs that are now available. And, we need to think about the entire spectrum of providers. So trainees now in the pipeline, as well as future trainees, but also providers that are already in practice. And so that's why, again, we can't just have, rely upon training curricula. We need to think about other ways that we can get current providers trained.
Awesome. And I did have another question kind of involving around training as well, in case you have any additional insight. Jamal asks, what are some good places to begin to gain free or low-cost training on how to handle the vets specifically pertaining to PTSD and other anxieties? Did you have any other thoughts on that?
There are a number of organizations. I would refer folks to the Center for Deployment Psychology. They are one of the partners with the STAR Behavioral Health Program. They also are partners with both the Department of Defense and the Department of Veterans Affairs in providing some of these cultural competency trainings. There's a program called Strong Star. So there are a number of programs available. We have not reviewed and vetted them all, but as I mentioned with the TIP tool, if you go onto the RAND website, we do have some case studies. And we did do case studies with Strong Star as well as the Center for Deployment Psychology. So you can get a good picture of some of the training programs that they're offering.
Awesome. Thanks, Terri. Rachel asks, is there any research or efforts on preventing PTSD?
So there have been massive investments by the Department of Defense to implement programs that would promote resilience and increase readiness of the force, with the belief that by doing so, you may minimize the likelihood that an individual would experience the psychological consequences associated with deployment. And so early on, there were some findings to demonstrate kind of a moderate effect size with some of these trainings for reduction in experiencing post-traumatic stress disorder. But really the literature hasn't borne out on whether or not these programs can prevent the onset of PTSD. It's also important to understand that PTSD can take years to manifest itself. And so even with some of these studies that have been done without the follow-up, 3, 5, 6, 10 years later, we won't know. And there's other life circumstances that can also occur. So it's really challenging to do the studies to see if we can prevent PTSD. I often have told people if we wanted to prevent combat-related PTSD, then we should stop sending troops into combat. But it would be really important to kind of look at, what evidence exists that we can prevent consequences of trauma. And I've not seen any strong evidence.
Appreciate that. What changes, and Sharon asks this, what changes supports are being implemented for active duty military with substance use disorders to get the help they need without punitive measures? More education and advocacy within the active duty systems will decrease what we are seeing with veterans. Any thoughts on that?
Great points. And again, I have not looked specifically to evaluate current efforts by the Department of Defense around substance use treatment or substance use behaviors. Our most recent study was focused on post-military, so the veteran population. But we do know that use of substances is a personnel related issue for DoD, and that there's testing for drug use and punitive measures that may occur if someone tests positive. And so we really need to kind of rethink how are we promoting healthy behaviors around use of substances and drinking in particular, and what can we do to ensure that those that experience problems get good care so that they can experience, recovery and achieve better outcomes.
Awesome. And this question is from Nicole. She says, do you believe that social networks for the veteran community, online specifically, and I'm assuming, kind of related to COVID, we've shifted virtually, can help support them in their mental health?
Potentially. So there, there is research to demonstrate that promoting connectedness can reduce risk factors associated with suicide. And certainly, if we want to promote connectedness with the idea that it decreases perceptions of social isolation, it may decrease perceptions of loneliness. These all can be important outcomes to do so, to reduce someone's risk of suicide and promote better health. We did a study a couple of years ago to look at the impact of online social networks for supporting military and veteran caregivers. And so ultimately, the impact of participating in these online social networks depends upon the nature of the engagement, the intensity of the engagement, and kind of the quality of the engagement. And so it's not just to say that more engagement with social networks has a positive impact. You have to understand a little bit more about the nature of that contact as well.
Awesome. I think I've got most of the questions answered. I think we have time for maybe one more. So Connie asks, have you seen a huge increase of veterans having contact with law enforcement due to PTSD and or substance abuse?
That's not a question I can answer. I do know that we are very concerned about justice-involved veterans as it may be a risk factor for other types of adverse consequences and may be associated with some behavioral health challenges or difficulties that they've experienced. There is, movement to develop and bring about more veteran treatment courts, and they are certainly showing some potentially positive results in how they can help to ensure that veterans get access to the needed benefits and services that they have, rather than, putting them into the criminal justice system. And so, while I have not studied the trends, the justice-involved veterans is a population of significant concern for us.
Awesome. Thank you, Terri. And thank you for answering all these questions. We've had a few resources and information shared within the Q&A and the chat feature. So we've been kind of keeping an eye on those, trying to make sure we answer everything that we can. If we missed anything, please continue to send it through, and we'll also obviously have time during our panel discussion if there's additional questions that we haven't got to during this portion with the keynote. And Terri has also graciously offered, if there are questions following this, that she can respond with some answers that we can send after this event as well. We will be happy to also share her contact information if you have further questions and you want to reach out to Terri for more information on the work that she's doing. So I do want to say thank you so much, Terri, for your time this morning and your insight, so much helpful information for this group. that is attending. And so I am going to pull up my screen so we can get ready to start the panel conversation. I think I have the wrong one. Hold on one second. All right. All right, so with that, we're going to move into our panel discussion. I'm going to introduce our moderator for this panel, Dr. Caitlin Thompson. She's the Vice President of Community Partnerships at the Cohen Veterans Network. She's responsible for establishing and maintaining critical national and local collaborations between the Cohen Veterans Network and public-private partners. She's a licensed clinical psychologist. She was the most recently executive director of the VA's Office for Suicide Prevention, leading VA's integrated public health approach to suicide prevention. Prior to her work in the VA Suicide Prevention Office, she spent 5 years as the clinical care coordinator for the Veterans Crisis Line. She has a BA in music from Brown University and a Master's of Education and a PhD in clinical psychology from the University of Virginia. And with that, I'm going to kick it over to Dr. Thompson.
Thank you so much, Christy. Can you give me a thumbs up if you can hear me?
Yes.
Awesome, great. Hi, everybody. Boy, is it a pleasure to be here today, and it is such an honor, as always, to follow my friend and colleague, Terri Tanielian. Just thank you, Terri, for such an incredibly packed presentation, so much that I continue to learn from you, and I'm really glad that everybody was able to hear that. And I think that it sets a wonderful foundation for our conversation coming up. So I am going to give a brief introduction to our amazing panelists, and then I'm going to ask them to, and you're welcome, panelists, to stop your video now so you can wave. But we will start with Dr. Kawana Ward. Dr. Ward, welcome. Dr. Ward is a doctor of Christian counseling, licensed clinical social worker, certified substance abuse counselor, certified sex offender treatment provider, and registered play therapist supervisor. Whew. So much to talk about here. Dr. Ward is the founder of Blakey Weaver Counseling Center Incorporated, which is a 501c3 nonprofit outpatient practice that provides mental health and substance abuse treatment services to veterans and other underserved adults in the Western Tidewater area of Virginia, regardless of their ability to pay. Welcome, Dr. Ward. Next, we have Dr. Mary Vance. Dr. Vance is assistant professor of psychiatry at the Uniformed Services University and a scientist at the Center for the Study of Traumatic Stress. So she's at USHS, as we like to call it. Dr. Vance's research focuses broadly on improving mental health care services and delivery for trauma and stressor-related disorders, particularly in the military, veteran, and healthcare professional populations. Welcome, Dr. Vance. So good to have you. Next, we have Mr. John Howard, who is a U.S. Army veteran. As I said, Mr. Howard is a United States Army disabled veteran. He served 8 years in the military. He is a veteran peer support specialist with the Western Tidewater Community Services Board. He's one of the original members on the first Orders Home Team in the nation to work in the community serving transitioning service members under the Clay Hunt Act of 2015. Mr. Howard is a dedicated veteran who seeks pride in encouraging all veterans to be the best they can be and to live in a community of their choice. Mr. Howard, welcome. So glad to have you here. Next, we have Michelle Bradford. Ms. Bradford is the Drug Abuse Program Coordinator to the VA's largest residential drug abuse program at the Hampton VA Medical Center, and she's been there for the last 8 years. She holds a national and state certification for treatment to substance use disorders. Ms. Bradford is a Navy veteran herself and a staunch advocate for women veterans, helping them to explore all treatment options as well as benefits afforded them. So welcome, Ms. Bradford. And finally, we have Dr. Aman Williams-Christians, who goes by Dr. Aman. So good to see you. She serves as the clinical director for the Stephen A. Cohen Military Family Clinic at the Up Center, which is one of the clinics that is within the Cohen Veterans Network where I work. So she is a fabulous colleague. A clinical psychologist with over 12 years of experience, she earned her PhD from Jackson State University, and she completed a postdoctoral fellowship with Strong Star, the world's largest research consortium for the detection, prevention, and treatment of post-traumatic stress disorder related to military combat trauma. And she is certified in prolonged exposure therapy and is which we can talk about what that is, and is currently completing the prolonged exposure consultant program at Emory University. Welcome, Dr. Aman. So good to see you. So I am going to start. I'm just going to start by asking our panelists some specific questions to each panelist, and then I'm going to open it up to more broad group questions, and then I'm really looking forward to questions that you, the audience, have. So let's get started. So I want to start with Dr. Ward. Dr. Ward, so we know that veterans who live in rural areas are at higher risk for suicide. We know that there are just a lot of concerns in terms of how to engage veterans in rural areas. It's a struggle that so many of us who have worked in this field have tried to manage, and you are managing very much yourself right now. So can you talk about how providers can best engage, build rapport, and treat veterans in rural areas?
Sure, thank you for having me. So when we're thinking about serving veterans in rural areas, we have to really recognize that there are challenges not only related to the cultural distance, but also related to the geographic distance. So in comparison to veterans that may live in suburbs or urban counterparts, we heard from the presentation that rural veterans do have a higher prevalence of both physical and mental comorbidities. And this is a lot of times related to culture. So rural veterans will value kind of focusing on the natural rule of order. Rural veterans have a tendency to describe themselves as down to earth. They'll be more likely to be employed at like high risk industries such as drilling or mining or food production or timbering. And these workplaces reinforce values of self-sufficiency and hard work. So when you have individuals who live in rural areas and who are more declined to work towards more of a pragmatic type of solution, healthcare providers should understand or take into consideration that these are also cultural values that make it really difficult for veterans in rural areas to ask for help. Even if resources are available in the community, it makes it very challenging for them to seek help outside of themselves. Rural culture really has the value of being self-reliant, and veterans in rural communities are more likely to be willing to talk to other veterans, their other family members, clergy members, things of that nature, than to go to a healthcare provider for mental health or substance abuse. So we have to really take into consideration the culture as well as the issues that are at hand. Our culture also really impacts their ability to seek treatment, even when treatment is available.
So many good points there. Yeah, really, really appreciate your perspective. Thank you, Dr. Ward. And, you know, I'm actually then going to jump to Mr. Howard, because Dr. Ward, you spoke about how veterans really prefer sometimes to speak with other veterans. And Mr. Howard, you're a peer support specialist in many, in your life. And can you talk about how peer support can play a role in recovery, and really just start out and explain what peer support is and what you do?
Glad to be here, and good morning to the panel. Veteran Peer Support is a program that we started here at Western Tidewater, simply just about someone that has been there and done it. I have lived experience from serving in the military, being a wartime vet, peacetime vet, and also transitioned somewhat our back to civilian life. So what we bring to the table is experience, how to navigate the VA, how to transition successful, and we just share. One of the greatest things that we can do is listening and share when it's appropriate our story to help the veteran to see the importance of having a successful transition. And what I always personally do as a veteran peer, I keep it in layman's terms to the veteran. As far as the mental health aspect or suicide, let's talk to them simply in their language. If you want to be the best you, then we need to give you the gear, the equipment, and the tools to be best you. So we walk beside the veteran. We help them to overcome their barriers, any issues that they're facing, whether it be substance abuse, mental health, homelessness, anything that they cross, we walk. We don't do it for them. So we have a trust already established because somewhat we've been there and done that. So it will allow us to come into the door just a little quicker than someone that has not served or maybe a professional.
Great, thank you. Yes, your audio is going in and out just a little bit, but I think we got most of the gist of what you said, which is really you walk the walk with the veterans and you talk the talk, and you are able to really connect with them through listening and sharing and supporting each other. So really appreciate that as well. I'd like to go to Dr. Vance. Dr. Vance, there are a lot of different reasons why people seek mental health care, and you have become an expert in trauma-focused work. Can you talk a little bit about what moral injury is, first of all, and some of the differences between what moral injury is, what post-traumatic stress disorder is, and what TBI is? Sometimes they get confused, and so I want our audience to really better understand what each of those is and how they can interplay.
Oh, turning off my mute here. Yes, absolutely. This is such an important question, and it is a confusing distinction because there's a lot of overlap. So to start with moral injury first, since you started with that question, we know PTSD and TBI as some of us know it as the signature wounds of war of this generation. Moral injury is not new, but it's newer in terms of being studied and recognized in this war generation. And, you know, unlike PTSD and TBI, which have a more consensus definition, and, you know, as a physician and a psychiatrist, I work with the DSM, the Diagnostic and Statistical Manual to Diagnose, and PTSD and TBI are in there, but moral injury is not. There's actually no mention, really, of moral injury, at least not one that I could find through the index. And that is because there is really no consensus definition as of yet. There are several definitions that have been offered, and it's certainly something that we're starting and still struggling to understand, you know, as a clinical community, as a scientific community. And it's been defined in both sort of systemic or leadership ways, as well as in individual ways. So one that's often used for a definition is that a moral injury consists of the lasting emotional, psychological, social, behavioral, and spiritual impacts of actions that violate a service member's core moral values and behavioral expectations of themselves or others. But it's also been defined as a systems or leadership failing, such as when there are rules or regulations or things that command, ask, or require you to do that transgress your own deeply held beliefs and moral values. And manifestations of moral injury can include guilt, shame, lack of forgiveness, either self-forgiveness or other forgiveness, depending on who the individual believes to be responsible, anger, trust issues, and importantly, spiritual and existential issues like loss of faith or questioning of faith or morality. And this really, this last spectrum is what, for me, really differentiates moral injury from the other better described phenomena like PTSD and TBI. There is a lot of overlap in how they can present, you know, guilt, shame, you know, anger. This can also be found, of course, in PTSD and to some extent, you know, lots of these feelings can manifest with a TBI presentation as well. But you can think of it that PTSD and TBI focus on the individual's reactions in and of themselves. Moral injury sort of expands our focus to think about the larger context within which individuals are placed. How the events unfolded, who was responsible, how events are interpreted within the moral and or religious and spiritual frameworks within which individuals live. Moral injury is not a clinical diagnosis, but it can impact how clinical symptoms present, and some service members and veterans might find that it actually describes their experience better than the clinical list of symptoms you find with PTSD or TBI. And just to then answer your question about PTSD versus TBI as well. So, I mean, a lot of us work with PTSD. So, we know that it is a psychiatric disorder. It develops after exposure to a traumatic event. And it's characterized by symptoms in 4 clusters: intrusion, avoidance, negative alterations of cognition and mood, and alterations in arousal and reactivity. And the symptoms need to be impairing. Now, if we think about the neurocognitive effects of TBI, and usually we're talking about mild TBI or essentially concussion.
And Dr. Vance, sorry, there was a question, what is TBI? TBI is traumatic brain injury. So let's just get to the basics before you get into the rest.
Absolutely, absolutely. I didn't see that question. I was focused on answering. So absolutely. So let's back up. TBI stands for traumatic brain injury. TBI describes the injury, not the neurologic or behavioral health consequences of the injury, actually. So, a traumatic brain injury involves loss of consciousness, post-traumatic amnesia, disorientation or confusion, or neurological signs like seizures or neuroimaging findings of injury after an impact to the head. So we can think of it as, the cause is an impact, commonly, in this day and age, a blast injury, blunt trauma, something like that. And then the behavioral health manifestations are described in the DSM as a major or mild neurocognitive disorder due to traumatic brain injury. Okay, so 80% of TBI within the civilian population is what I said is mild TBI or concussion. Most of the time that resolves within weeks or months, but sometimes it persists and it can lead to a host of different symptoms: headache, insomnia, memory impairments, concentration difficulties, irritability, feelings of depression, anxiety, behavioral dysregulation, and there's a lot of comorbidity between PTSD and TBI. And in fact, studies have found that if you have TBI and the associated behavioral symptoms, you can increase the risk for developing PTSD as well. So that's why it's important to understand the overlap. And as behavioral health focused folks out there may know, there's a lot of overlap, but we might miss the question of traumatic brain injury if we don't ask about it. So I definitely recommend screening those individuals that you're serving for TBI, and consider alongside with PTSD with questions such as, have you ever had a period where you lost consciousness? Tell me about that. Have you ever been hit in the head with anything or had a blast injury? And that's an easy few questions to start thinking about TBI in concurrence with PTSD or not.
Great.
Hope that starts to get to some of that question.
Definitely. Thank you so much, Dr. Vance. Great. And moving from the description of PTSD and TBI and moral injury, Dr. Aman, you are an expert in treating PTSD, post-traumatic stress disorder. Can you speak a little bit about how providers can make sure that there's a safe space for veterans who come in and need that treatment for PTSD? And also with your expertise in prolonged exposure therapy, can you speak a little bit about what those individual types of interventions are for PTSD?
Absolutely. So when working with veterans, or we also work with military family members who have PTSD, it's important to make your environment as calming as possible. When we were originally building this clinic in Virginia Beach, there was artwork that was put up of, and it was very nice artwork of military ships, of homecomings and different military paraphernalia. And all of that is really great, and we have that throughout the clinic, but not in the waiting room. When that is the first thing that someone sees who has PTSD, that can be very triggering for them, it won't make them feel safe. So one of the things we did was we were very purposeful in making it a very calming environment. We are lucky that we are in Virginia Beach, so we have a lot of beachy things and a lot of blue. We have lamps that have calming lights. We also have, we call it the quiet room, but it's a secondary waiting room for those who possibly don't want to be in the larger lobby where there could be kids running around, or we have a designated child space as well. But it can get noisy if quite a few clients are waiting. So they have the option of going into that room, and that room is even more soothing. We have a noise machine. We have a candle, all kinds of things to make it really feel spa-like, is the word that we've heard. And we always ask people who are coming in for the first time, what was your experience like? And one of the things we asked was the location, was the lobby good for you? And overwhelmingly, we get good feedback for that. So it's very important to set the environment. It's very calming. And even when they come back into the clinician rooms, we really allowed the clinicians to decorate their rooms however they wanted. However, we did go in there and try to make sure that there was nothing super triggering in there. I'm thinking of one clinician in particular. He had a painting done by a friend, and it was a beautiful painting, it truly was, but it was mostly red. And so someone coming into a room and there's this huge red picture, it can stop you in your tracks. And so really being purposeful and making your environment feel safe. So getting on to treating PTSD, there are 3 evidence-based treatments for PTSD: prolonged exposure, and that's where my expertise is in, cognitive processing therapy, also called CPT, and EMDR. And prolonged exposure is basically where you are revisiting the memory in a safe place. So they're actually revisiting the memory during the sessions. And they're also asked to engage in activities that maybe veterans have felt like they can't engage in. A very common one on the list is going into a Walmart. We all take that for granted, that is just a very normal activity. But for someone who has gone through trauma, being in crowds and in confined spaces, or places where there's maybe only one entrance and one exit, that can be very distressing for some people. And so getting them to step by step engage in some of those activities, all with the goal of bringing their life back, getting their life back. Because usually the spouse will come into a session and say, this person is not the person I married, or when I met them, and how can I get that person back? And the person's not going to be exactly the same after treatment, but they are going to feel like, okay, I have purpose in my life. I can live again. And so that is the ultimate goal of prolonged exposure.
Fantastic. Yes. Great. Thank you, Dr. Aman. Ms. Bradford, thank you so much for all the work that you've been doing at the VA. Can you speak a little bit about how the VA's responded to, there's some stigma, and particularly for veterans, about seeking mental health care. And can you talk a little bit about how the VA helps with that? And also, Terri spoke so well about the importance of military cultural competency in terms of our treating our veterans. And I know that there are a lot of private providers in the audience and civilian hospitals. Can you also talk a little bit, and as a veteran yourself too, about the importance of military competency when you're treating veterans?
Absolutely. Thank you for having me. So yes, the stigma that comes along, a lot of times it starts well before the military. You'll hear people say, I was taught we don't talk about this outside of the house. We don't talk about these things. It shows weakness if you have a mental illness. And then so people go into the military and that's reinforced. A lot of times people are afraid of, like they said, losing their clearance or being transferred away from their command or having their peers look at them differently. And so that just gets reinforced over time. So by the time they come into the VA, we get a lot of people that are in pretty bad shape. I work in residential care, so some of the people either come from inpatient psychiatric units or they come in, and our goal is to keep them from needing that next level of care. But oftentimes they need more than just the 1 time a week or 2 times a week. They need day in and day out care. And so what we do is we reinforce, doesn't it feel better to let some of this go? How has it benefited you to hold on to the stigma and not get care based on the beliefs of how others feel or perceive this? And when they can let that go and be free to get the care that they need, we just see doors open just in multitude, tenfold. And it's wonderful to see that. So again, with that camaraderie of being with their fellow veterans, they feel safe discussing it in an environment because they know, A, this person is likely seen or done what I have done. So they have a better understanding. They know the nomenclature. They know, they just get it, for a lack of a better term. And then, so the military culture, a lot of our people treating veterans here, like myself, are also veterans. The program in which I work, I think we maybe have 3 people that did not serve in the military, but their family members did. So they're once removed. So they again know the language, they know the culture, and they understand a lot about what's going on.
Yeah, so important. So that when veterans come into care, they don't have to explain what their rank meant or what the difference between what they did, what Army or versus Navy does. It's so important to have that so that they can just be focused on themselves and not in educating the provider. So really appreciate that follow-up and that background. Can we talk, so we've talked a little bit about PTSD, we've talked a little bit about TBI, but I'm wondering, and maybe Dr. Ward, we can get back to you for a moment, but can you talk about some of the other types of mental health concerns that you treat and that you see and that we're managing in the military? And also perhaps if you've seen an increase in anything since we've had the COVID pandemic.
Yes. So in the rural areas, I see a lot of anxiety, major depression. I see a lot of manic depression as well, and serious mental illnesses. A lot of what I see is connected to someone who's been in the military, maybe even retired from the military, and whatever they did in the military is not transferable in the civilian world. So that it's the transition. It's the transition of coming from a career that they're very proud of and very celebrated and declarated in, and then they come into the civilian world where it doesn't quite fit. And they don't know how to speak the language. They don't know how to adjust and transition. And so that results in anxiety, a lack of confidence and self-worth. And a lot of times you'll see them draw into themselves. They'll seclude in rural areas because, again, that's the place that they feel safe and they are able to be themselves. And so we see that a lot. With COVID in the rural areas, because for some of my veterans, they appreciate COVID because, again, they don't need an excuse to practice social distancing. They don't need an excuse to say they don't want to be out and about and bothered. And so a lot of them are finding comfort in being at home. The rural area that I serve, a lot of my clients don't have internet. And so, we take for granted when you live in a suburban area or a metropolitan area where you have access to cable TV and a smart screen or a smartphone. Many of my clients, specifically veterans, still have flip phones and they still are paying for internet services, broadband. So they have to either, wait until after 7 o'clock to use their minutes, or if they are getting any type of subsidy, their subsidy only gives them a certain amount of minutes or a certain amount of internet. And so they have to pick and choose, you know, do I see my primary care, or do I help my daughter with her schoolwork and use this internet? So they're faced with some challenges as it relates to COVID. It's kind of a mixed bag because again, like I said, for some of us who are active and involved, you know, we miss being able to socialize, but for many veterans, specifically our combat related veterans, they are enjoying this time away. They are enjoying this time of peace and being left alone.
Yeah, thank you. That's really, really interesting. And actually, I'm going to go to Mr. Howard. How can we partner? I know there are a lot of community organizations that are in the audience right now. And from your perspective, how can we all partner together so that we can make sure that we're serving our veterans' mental health needs outside of more formal providers like the VA or like Cohen Veterans Network?
One of the things we did here, we already use the term, we laced our boots, put boots on the ground. This program, which was started off as a pilot program here at Western Tidewater, partnered with the VA in Hampton. What we did for the first 6 months, we went out into the rural communities. We went everywhere that we could find veterans. We advertised, we went to the local newspapers, we went to unemployment office, we went to the religious leaders, we went to restaurants, we went to social services, we went to mental health professionals. Just imagine anywhere, we went to thrift stores, anywhere that you can imagine where a veteran might be. We went out there and advertised and put our information out there, let them know that we are in the community. We partnered with the VFWs, DAVs, the American Legions, those, especially in the rural areas. A lot of those veterans that do like to isolate, they will still connect to some type of veteran organization, something like that. So we went there and built a partnership, built that trust that we are in the community and stuff like that. So really and truly, for veterans, show up where they are. And if you show up where they are, they will open up and they'll be more up, to take help. We even had groups, our team, at the local restaurants, Dairy Queen, McDonald's, wherever the veteran want to meet us, library, wherever he was comfortable, we made sure that we had our literature there and we would be there. We would staff someone in a community. Me personally, I covered Franklin's, Isle of Wight, Southampton, that's down here in the 757 area. I went every day, went back, checked in, hey, I'm here. If you need me, call me. And we had a good result because we had a lot of people and agencies that reached out to us and gave us a chance to present and tell our program and what we're willing to do and let them know this is a free program. I don't like using the word free, but the veterans earned it. They deserve it, and we're here for it. And when they had veterans come in, they will begin to screen, begin to ask a lot of their clientele, are you a veteran? Are you a caregiver of a veteran? Are you a spouse of a veteran? And then they will say, well, we have this program that has veteran peers that help with transitioning, help with any type of barriers or issues. And they would just get our information to them. We field the call. But it's being available, getting down, talking to everybody. Everybody matters. I mean, we hung out at Walmart.
Yeah.
We went anywhere. So
that's awesome. Boots on the ground. I love it. It's so important to just be out there. And even right now with the pandemic, when you can't necessarily be everywhere physically, it's, using things like social media or, sending things out. But really, yeah, it is just being there, being available, because that's the only way that people will understand where you're coming from.
And I'd like to add on to one thing
Sure.
that mentioned in the rural areas. We just tackled this issue about a week ago. A lot of them do not have internet. Some of them don't have email addresses, something like that. So what we did, we created a warm line. And when we created a warm line, we did not take into consideration that minutes on the phone. So we had to go back and revamp it and get a toll-free number so the veterans wouldn't lose the phone, because we were thinking selfless. We weren't thinking about the veteran that might not have unlimited access to internet or to phone service or text or something like that. So you really have to be creative, think outside the box, how to reach all veterans. And that is one thing that we really have to do as a team, is to partner with it. And we always talk about wraparound service, but we're not stepping on anybody's toes.
Yep.
We just bring the best care to the veteran that they deserve. We all are in this together. So just build those partnerships and put the information out there.
Absolutely. Thank you. Thank you. Couldn't have said it better. Dr. Vance, there was a question I saw in the chat, just very briefly. Can you talk a little bit about how traumatic brain injury is diagnosed? What are some of the things that go into actually diagnosing it, just really briefly?
Sure, absolutely. Traumatic brain injury, especially the mild form, the concussion, can be made as a clinical diagnosis. So essentially asking the question about whether you've had an impact to the head, whether after you experience symptoms such as headache, dizziness, loss of consciousness, forgetting, amnesia, essentially, then it can be made. I mean, in some cases, you might go in for imaging studies to, essentially take pictures of your brain and see if there's anything to be seen. But that's not always necessary, especially in mild cases. So you can simply ask the question.
Great, thank you. Very, very concise, excellent. I want to jump into some of the questions that have been coming up because I think there's some great ones. And I want to start with Ms. Bradford. We got a question about disability ratings. So the question is, I imagine that to get access to many of these services for VA, vets will need a disability rating. For those of us in case management, how can we help them access and navigate the VA disability rating pursuit?
Okay, so one of the easiest ways to do that is to work with your local DAV, disabled veterans. They can help you if you don't have your DD-214 or your medical records to obtain those, because you're going to need those to apply for benefits. And so once you get that ball rolling, what they will do is set up an appointment, whether it's medical or mental health, and they'll do what's called the C&P, compensation and pension exam. And from there, it goes to a rating disability board for rating.
And what are some of the organizations, I know that DAV and other
American Legion does it.
Yep.
There's a group at William & Mary that also does a fantastic job. So for people up in Williamsburg, they are highly recommended.
Excellent. Maybe we can send out some of those resources to the participants afterwards. Great, appreciate that. Dr. Aman, can you speak? I know that we were talking about the very rural veterans who have don't even have the internet, don't have access to the internet, and have difficulty with minutes on phones and that sort of thing, which is just really unfortunate in many ways. For those who do have the internet, I know that Cohen has been doing has been able to shift over to telehealth. Can you just speak to what telehealth is and how people are getting care through telehealth and how effective it is?
Yeah, so video, telehealth is video or face-to-face conferencing. So with what we're doing now on Zoom, on your computer, or on your tablet, a lot of people use their phones. And you're receiving treatment with your provider. They may be at home or they may be in their office like I am now. The research has been really encouraging and has shown that therapy is just as effective with telehealth as it is in person. With COVID hitting, we were already prepared because we already had telehealth in place and the infrastructure to have that going. And so the transition was very easy. The clients really do enjoy it. There are some clients who prefer in person. And so as rates of transmission of COVID have come down, we've started inviting some clients back for that in-person touch, but a lot of people really do enjoy telehealth. A lot of them do therapy out of their cars. I feel like there really could be a movie made about that because it's fascinating what you learn about somebody from looking inside their car. Yeah, we've had great success with telehealth for sure.
Fantastic, great. Dr. Ward, there is a question about from somebody who works at a home care agency. how can they best serve veterans, and perhaps with your work with rural veterans, and but just kind of understanding the care of veterans. What about it with a home care agency, and then I'll open that up to others if anyone has other thoughts.
I think that when we're serving veterans, we need to allow the veteran to be the expert. You know, even though we have experience working with veterans, I think that every veteran is unique. And I think that we need to surrender the one up and allow them to be the experts of their story, and try to be as culturally sensitive as we can be. But I think if that is our best tool, you know, allowing them to be the expert of their story, their needs, and us being a support. And not, a lot of times veterans, just like any other clients that we work with, they don't expect for us to solve the problem for them. They want us to be a resource of support. And so allowing them to identify how we can support them. What is it that they need? Allowing them to also write their own narrative about their story. So going in as a support system and not the expert.
Yeah, boy, is that great advice. Do any of the other panelists have thoughts on that? Yeah, Mr. Howard.
As a veteran peer, here we always will encourage the veteran, you know, you are in charge of yourself. You are the expert of yourself. So we always will just listen to the veteran and encourage him. Like me personally, I would share with the veteran that I have never read a book, just one chapter in the book. Your military service, great. What you experience is great. It's a part of you, but that's only a chapter. You want to write the next chapter as best as you can. And we just try to encourage them and equip them with the tools that they can to be successful in writing the remaining chapters of their life. Yes, you always will be a Marine. You always will be a soldier. You always will be a sailor. You always will be an airman. But one thing you definitely will always be is a veteran. And be the best veteran you can. You can take charge of those things. Once again, we always use the lamest term, like military equipment, tools. Let me get you to training. And that also transfers back to mental health professions, also goes back to medication. If you need the equipment as a soldier to be the best warrior you can be, you need that. So you might need your medication. So we always encourage them to build themselves up by listening first and sharing some tools that have helped us along the way. Also, too, I want to go back and mention to Ms. Bradford, another agency, one of the questions that was in the panel, another agency that Virginia has that is outstanding that can help veterans with benefits, and that's Virginia Department Service. Virginia Department of Veteran Services. Virginia Department of Veteran Services is an outstanding one. They actually have benefit agents and resource agencies there at that state institution that can point a lot of veterans in the right direction. And they are really well trained and they are outstanding at what they do. But encouraging the veteran to be the best them be. I like to coin the phrase, let's be a wellness warrior. You know, we always push the warrior mindset. Hey, you're a warrior and you go in the military. First thing they give you is gear, equipment, tools of the trade. Second, they give you training to be the best warrior, the best soldier, sailor, Marine you can be. So now that you're a veteran, let's be a wellness warrior. Let's take all of those tools that you need to be the best you. If that means medication makes you the best you, then let's get that medication. Let's get that tool in your life. You know, if you need to see a clinician, let's get that equipment in your life. That way, we try to engage them that way.
Beautiful. Wow. So well said. Thank you. Love it. Dr. Vance, there's a question about virtual reality. Do you have any, in treatment with veterans, do you have any experience with that, or do you know anything about the, any of the research that's been done?
It's a good question. I am not an expert in virtual reality modalities, although I know that it's sort of an up and coming area of research, you know, as technology improves and as we get more creative with our solutions. I have heard of some evidence showing that for certain veterans it can help, and that can be with PTSD and TBI. But I don't want to, you know, kind of speak to the literature without having, without knowing the details of it. But kind of to echo the point that Dr. Ward made is, and Mr. Howard too, is that there's no one-size-fits-all approach, right? We heard that with Dr. Tanielian's talk too. And so we can think of virtual reality as something that augments and increases their range of resources. If that works for them, as this gets more rolled out and is backed by more evidence, you present them with a choice. What kind of treatment do you want? Some people are, maybe respond better to these types of modalities. So I see it as a positive change in the field whenever we start to offer more treatments and have more evidence base to support them.
Fantastic. Yep. Dr. Rahman, do you have any follow-up with what Dr. Vance said?
Just that I know most of the research is coming out of Emory University under Dr. Rothbaum, and I happen to know her because of she runs the Prolonged Exposure Consultant Program that I was part of, and yeah, the literature coming out of there is fascinating. One of the things that researchers in the field are looking at is, we know we have these great evidence-based therapies, and yet there are a certain percentage of veterans that do not respond to them. It's a small percentage, but there is a percentage. And so always looking for things to augment the therapy or present it in a different way. I really do appreciate those efforts. And so I'm looking forward to the virtual reality becoming more mainstream.
Fantastic, thank you. Okay, so we have a couple of peer support questions. So I know that VA, so Michelle, perhaps you can speak to this a bit, Ms. Bradford, about the peer support specialists who work at the VA, and also Mr. Howard, perhaps you can speak to the question is, do peer support specialists provide support with justice-involved vets? So through the Veterans Treatment Courts and other things like that. So we can start with Ms. Bradford and then jump to Mr. Howard.
Well, what we have as far as our peer support here, as far as veteran justice outreach, normally what they do, will work with them after they've gotten released from jail, maybe even to come into treatment. And then so a lot of times they'll work with them through second chances to help get certain things expunged from their records if they're old enough, so that they can get certain rights back. Depending on what it was, there are different things that peer support will do with the veteran as far as veterans justice. Absolutely.
Yeah. Great, thank you. Mr. Howard?
Yes, ma'am. What we do it based on the individual veteran's needs or what the individual situation is. This team here, the team that I've been a part of, we actually had a chance to put a major footprint in the justice system through the DOD. We actually ran our group out of the brig, the military prison in Chesapeake, which I felt personally was a population that was forgotten about. You're dealing with veterans transitioning from the military, well as transitioning from prison. And what we do, we talk and work with them one-on-one about some of the things or the challenges that they had individually. And then we encourage them when they go back to the home of their records to really look at seeking out, is there a veterans court in their home of records? You can maybe get some of your records expunged. We look at case by case, because some veterans that has been incarcerated while on active duty that we found over the last year and a half is that some of them was diagnosed with depression, anxiety, PTSD, substance abuse, and stuff like that, which caused them. Some of them never had a hiccup in their career. I mean, several re-enlistments, never had a problem. And then they developed some issues over things that out of their control. So we encourage them to really put in, try to get their record expunged, try to get your records overturned, show that you was a outstanding service member for years, and then you ran into some problems. A lot of them was not treated because of what we talked about earlier. The stigma of losing a clearance, the stigma of promotion. I mean, getting promoted to the next level. The stigma of your peers looking at you like you're not a perfect warrior. There's not a perfect human being, so there will never be a perfect warrior. So we address those needs of those transition service members individually and encourage them. Also, to really push the VA now. One thing about came into effect that really has helped veterans across the board in 2019, they signed the Mission Act, which pretty much gives access to veterans no matter what their discharge is for mental health or substance abuse. Also, great job, Stephen A. Cornson. We was there at the groundbreaking when they opened the facility in Virginia Beach. They deal with 9/11, post 9/11 veterans, but they take any veteran no matter what their discharge is, which is a big help. Some of these veterans ran into some problems and was forgotten. But by the grace of these programs and what we're doing here in different organizations and partnership, we're getting the word out to them that they are eligible for some care. They are eligible for community care, and we care. You serve your country. You deserve to be heard, and you deserve to get the treatment and the help you need to be the best veteran that you can be.
Yes, thank you so much for saying that. And, you know, Mr. Howard and everybody, this is one of the reasons why I'm most proud to work at Cohen Veterans Network is that we serve veterans regardless of their discharge status. I think that that is just essential. We basically say that if you've served one day in the military, you deserve care. So it's so important to provide care to all veterans because, as you said, they all deserve our care. Similarly with our military families, our children, our military spouses, and others. One quick question, and I wonder if Dr. Vance or Dr. Amon might be able to, or Dr. Ward might be able to speak to the scientific research about the positive outcomes around virtual appointments or around telehealth. I know that there's research there, but can any of you speak to that?
Go ahead, Dr. Vance.
Oh, I was just going to say that I would have to do some digging around to see if there are any updated studies. I mean, this is going to be much more studied now in the post-COVID era. The studies take a bit of time to come out. You know, speaking from clinical experience, I see patients and supervise trainees who see patients at Walter Reed, the military hospital, and it's much easier to make it to appointments, right? You don't have to leave your home or your car. I mean, as long as you have a working internet connection. So rates of no-shows have gone, you know, way down. You know, cancellations have gone way down. It's easier. It is more accessible, despite some of the barriers that we discussed. So that's a positive. So there are many of this, you know, this clinical anecdotal, you know, information that we could give. You know, and different service members and veterans have different preferences, right? Some are, you know, just really need that in-person connection. And sometimes that's really necessary. For others, hey, I don't have to leave my home. I don't have to drive, you know, 30 minutes to 2 hours to get to your clinic. That's great. I'll show up to every single appointment now, right? So that's definitely, you know, improvement in follow-up care. And so I'll defer to Dr. Iman now.
Great, thank you.
Yeah, you said a lot of the things I would say. So I'll just add that this has been studied for 15 plus years, telehealth services. And what they've consistently found is that there's no difference between a person coming in person or doing their treatment virtually using telehealth. So the research is very positive. I am looking forward to the studies now that more people are using this platform. And I'm curious how it's going to change our culture some. I can tell you from our experience at the Cohen clinics, when we started telehealth, we really thought that we would be reaching more to rural veterans, but what we found is it's actually those who live in big cities like the DC area, or I've lived in Texas in the San Antonio area. They really love telehealth because they don't want to make that long drive to their appointments or have to take off from work. So it's been really useful. And same as Dr. Vance has said, we consistently see that when we use telehealth, our no-show rates are lower. So having that accessibility. And then we also offer the flexibility of you can come in person, but next week if you want to do telehealth, that is perfectly fine. So we set every client up for telehealth at the very beginning, and that's been really helpful.
Awesome. Thank you, Dr. Aman. There's a final question about establishing more peer support groups in non-treatment settings like DAV, American Legion, vet centers, and the VFW. Mr. Howard, do you want to take that one? Just very briefly, because we're running out of time.
Yes, ma'am. As far as getting peer support, there's training that's available. You just can Google where you can get some peer support training. A lot of it's free. Personally, I was trained by Mr. Tom Pratt at Hampton VA. He was my mentor and trainer, and he came out and trained us or something like that. So there's plenty of opportunities. I do recommend that DAVs, VAWs, American Legion, any organization that touches veterans, look at adding a peer. I know one thing that the VA is pushing in the future is putting peers in clinics. They're talking several putting peers on warm lines, geriatric peers, so we can check on our veterans that are homebound that can't get out, so we can check on the older veterans that have served this country. That generation before us deserved the care and attention that they get. A lot of them don't have family members. So you can just Google peer support. I know there's a training in your area for it. It is a great opportunity. It's a good training. It's about 72 hours in classroom and stuff like that, but it is available, and it is a state certification through Virginia, so you can also look there. And it does help, because think of a battle buddy, think of your peer, someone next to has been there and done that. And also too, you get an opportunity to learn from your fellow veteran. As a peer, I learn every day from the veterans that I show up to work with. They teach me so much about everything. So listening and sharing, but listening is the most important thing, because a veteran will tell you how to help them, empower them to be successful if you listen. But you learn so much as a peer, because you realize that, hey, it's a struggle out here. I'm willing to walk that struggle with you by just listening. Saying the training is outstanding. Just Google peer support and look up Virginia State peer support training, and it's there. It's available.
Fantastic. Thank you, Mr. Howard. So, Christy, I think we have 4 minutes left. Do you want to come on back on? Welcome back.
Absolutely. Thank you all so much. This was so insightful. I actually want to read out a little comment that we had from Ruth Anderson Cole that said, "Thank you all for an amazing presentation, extremely informative, well-rounded panel." So thank you for participating today. Thank you for all of your input and expertise and information that you provided to this group today. And with that, I'm going to wrap things up, since we are almost at the end of our session for today. All right, can you guys see that okay? All right, so with that, I want to pull up just a reminder that we really need your feedback. I encourage you to open up your mobile phones, and if you can click on your camera, you should be able to hover over this QR code and be clicked on a little tag at the top should say, click here to go to our SurveyMonkey feedback form. If you could please go to that and provide us feedback on today's training, that would be so helpful. We've also entered the link in the chat box, and we will be sending you a link following this event if you're not able to get into it immediately following this training. So please provide us feedback. Again, this also gives us an opportunity to understand what future training topics that you're interested in. The Regional Community of Practice is designed to help us get feedback from you so that we can put on training events like this one that really provide you the information that you need to better serve our military and veteran populations. So with that, lastly, for those that do need CEUs, please email Janae Tyler at jtyler@every-mind.org if you need a CEU certificate for today's training. She is going to be emailing those out towards the end of this week. So those will be coming out to you shortly. We do encourage you obviously to fill out the survey feedback first, And once you've done that, we will be emailing out that PDF of your certificate to you soon. And if you registered, when you registered and selected that you needed a CEU, we'll be using that list first. If you forgot to select that option or you need a CEU, again, just be sure to email Janae and she will make sure we get that sent over to you. So thank you all for joining us today. Thank you again for our speaker and our panelists and our moderator. We appreciated their time today and expertise, and we hope that you all have a wonderful rest of your day and enjoy, you know, our new start of October starting tomorrow. All right, thank you all.